The most valuable tool an EMT can possess is excellent patient assessment skills. While there are differences between how we assess medical and trauma patients, the initial approach is largely the same. For all calls, take standard precautions for body substance isolation based on what you know of the call. Gloves and goggles are a minimum for every call, but some may require a gown or face mask. The scene size-up actually begins with your dispatch information. What you are told about the location of the call and complaint can give you information about what to expect when you arrive. For example, if you are responding to a tavern, you might expect alcohol to be involved in the emergency or large crowds to be present. Upon arrival, ensure the situation is safe to enter, meaning that there are no hazards to the safety of you or your crew, such as a loose dog, poor lighting, or a fight in progress. Determine the number of patients who need your attention and whether or not additional resources, such as ALS responders, law enforcement, or lifting assistance will be required. In the event additional resources are needed, call for help now. Once the scene is secure, determine the nature of illness based on the patient's chief complaint and initial presentation. In some situations, you will arrive to find the patient unconscious. If the patient is unconscious, bystanders or seeing clues such as medicine bottles may give you a sense of what you were called for. Another consideration is spinal immobilization. While we normally think of spinal immobilization for assessment of the trauma patient, it is not uncommon for a medical emergency such as a seizure to cause the patient to fall to the ground, potentially injuring the spine. In a scenario where the patient has fallen or presents to you on the ground without explanation, begin manual immobilization of the spine now until you are able to confirm that a spinal injury is unlikely. Your primary assessment should be done in the same way every time on every patient. The purpose of the primary is to find and correct life threats such as apnea or hemorrhage. Having a consistent approach to the primary assessment will ensure that you identify the most pressing, life-threatening issues with your patients every time. Determine the general impression of the patient. This is often stated as a level of distress, such as mild, moderate, or severe, sick or not sick, or as an obvious complaint, such as respiratory distress when a patient is tripoding and has audible breathing. Next, determine the patient's level of consciousness. Discover whether they are alert when you come in, meaning that they are aware of your presence. If they do not seem aware that you have arrived and are presenting with their eyes closed, attempt to gain their attention by using loud verbal stimuli, and if unsuccessful, appropriate painful stimuli such as interdigital pressure. If they do not open their eyes or speak to either verbal or painful stimuli, they are said to be unresponsive. Regardless of level of responsiveness, introduce yourself and attempt to gain consent to treat the patient. Of course, you may treat an unconscious patient using implied consent. If the patient is alert, ask them for their chief complaint or the main reason you were called. In the event of an unresponsive patient, you may be able to determine the problem from bystanders or the scene itself. Your assessment of the airway is next. You will need to confirm that the airway is open. In a situation where it is not, open it now using a head tilt chin lift since this is a medical patient with no spinal compromise. Look inside the airway to make sure there are no obstructions or substances that need to be suctioned. If suctioning is required, clear the airway now. If this is a situation where it appears that the patient is unable to maintain a patent airway, such as in a patient with an altered level of consciousness, insert an OPA or NPA now. Assessment of breathing comes next, including respiratory rate, rhythm, and quality. You will also need to determine if the patient has adequate tidal volume. You should bare the chest to check for any scars, such as from open heart surgery, medication patches, medical alert tags, or implantable devices or ports. A bare chest will also help you listen to lung sounds without interference from clothing. In addition to auscultation and inspection of the chest, you will need to palpate the chest wall for stability and to ensure that the patient doesn't have subcutaneous emphysema, crepitus, or pain on palpation. Oxygen should be applied now if it is indicated. For respiratory rates less than 10 or greater than 28 to 30, or for inadequate tidal volume, Ventilation should be assisted using the bag valve mask attached to 100% oxygen. Most commonly, the radial pulse is used to assess circulation of a medical patient. If a radial pulse is not present due to poor perfusion, move to the brachial or carotid pulse. Check for pulse rate, rhythm, and quality. Of course, if no pulse is present at any arterial site, begin chest compressions and call for an AED. Assess the skin for color, temperature, and moisture. Another way to assess for distal perfusion is by checking capillary refill time by putting pressure on the nail bed and counting the number of seconds for blood to return to the area after it is blanched. Normal capillary refill time is less than 2 seconds, indicating adequate distal perfusion to the extremities. Some patients may present with bleeding. Control any major bleeding if present and possible. You can begin to control external hemorrhage with direct pressure. In some situations, a patient will present with internal bleeding. Internal bleeding from, say, an ulcer obviously cannot be controlled by EMTs. Therefore, you will need to begin treatment for shock, which includes lying the patient down with legs elevated and covering him or her with a blanket to preserve body heat. While you already determined level of responsiveness using the AVPU scale, it is now time to determine level of orientation using the patient's answers to questions about their name, time of day, current location, and events leading up to the EMTs being called. This is called alert and oriented times 1, 2, 3, or 4, depending on how many questions about person, place, time, and event they answered correctly. You could also use a Glasgow Coma score to report level of consciousness, although the GCS was designed for use in trauma patients. Now is the time to assess pupil size and reactivity to light as another measure of neurological activity or disability. Depending on the chief complaint, it may be necessary to expose other body parts for assessment. If needed, do that now. Based on the information gathered in the primary assessment, identify and treat any life-threatening conditions. Any insult to airway, breathing, circulation, or neurological disability, including altered mental status, indicates a critical patient. If the patient does have life-threatening conditions, begin treatment or transport now. If no life-threatening conditions exist, you will likely stay on scene for a while to gather more information. The only situation in which the primary assessment should differ in order to the above is when you believe the patient to be in cardiac arrest because they seem to be not moving and not breathing, and if checked, to have no pulse. In such cases, begin chest compressions immediately before any other assessment is performed. While vital signs are actually the first part of the secondary survey, it is unlikely that you will take these yourself as you will be busy talking to the patient. It is appropriate to delegate vital signs to a partner so that the information can be gathered simultaneously during your history taking. Your partner can inform you of the measurements for you to note on the PCR as you take the patient's history. First, gather a history of present illness by asking the patient what happened today to make them call EMS. Once a chief complaint is obtained, you can ask questions to clarify the complaint. For a complaint of abdominal pain, for example, you might ask about anything they ate recently, other substances ingested, or about bowel and bladder habits. These are called questions related to the chief complaint, and learning these questions will keep you from asking the patient unnecessary questions. These questions help you determine associated signs and symptoms and pertinent negatives. The mnemonic OPQRST can help explore a complaint of pain. O stands for onset. You would ask what the patient was doing when the pain started or what caused it. P stands for provocation and palliation, meaning what makes it feel better or worse. Q stands for the quality of pain. To assess quality, you will ask the patient to describe what the pain feels like. They should give you an answer such as sharp, tearing, or pressure. R stands for region and radiation, meaning where it hurts and if that pain moves anywhere, such as to the neck, jaw, back, or shoulder. S stands for severity and should be rated on a scale of 1 to 10. T stands for time or timing, meaning when the pain started and whether it is constant or comes and goes. Next, get a sample history to include signs and symptoms, any allergies the patient has to medication, food, or the environment, any medications the patient is taking or supposed to be taking, including any recently started or stopped, any herbal or over-the-counter preparations, pertinent past medical history, last oral intake, which is especially important when treating possible diabetic or allergic emergencies, and events leading up to the present illness. Once you have finished the history gathering, check in on the vital signs you delegated or take them yourself now if necessary. You will want to know the patient's pulse, respirations, skin signs, pupils, and blood pressure. You can gather other diagnostics now if you have them available to you, such as pulse oximetry and blood glucose monitoring. The body system to be examined first should be related to the chief complaint. For our example of abdominal pain, the abdomen would be examined before the head, neck, or chest. If the patient is unconscious and cannot relate to you the chief complaint or nature of illness, then it is appropriate to do a full body check or head-to-toe assessment, which begins naturally with the head. Use the tools of inspection, palpation, and auscultation to find any abnormalities that might be contributing to the patient's condition. For example, when checking the neck, jugular venous distension could indicate heart trouble. A distended abdomen could indicate infection or bleeding in the abdominal cavity, and swelling of the feet or hands could indicate heart failure. Don't forget to check the posterior of the body for bleeding, incontinence, or other clues to the patient's condition. Decide what you think is likely the problem, called your field impression, and inform the patient, family, and your team of the treatment and transport plan. As soon as time permits, usually every 5 minutes for unstable patients and every 15 minutes for stable patients, reassess your patient. Depending on the patient's condition and your treatment and transport plan, reassessment may be conducted at the scene or en route to the hospital. You will repeat your initial assessment, or ABCDs, including the chief complaint. Now that you have more information, determine if the chief complaint has changed. Take another set of vital signs. It is your goal to get serial vital signs, or at least 3 sets prior to transfer of care. Serial vital signs allow you to trend the patient's condition as it gets better or worse. Evaluate the patient's response to your treatments. For example, if you assisted a patient with his inhaler, does the breathing seem easier? The respiratory and heart rates slower? You should also be sure your interventions are still in working order, such as the oxygen tank having enough oxygen to continue the non-rebreather or nebulizer treatment. If anything has changed or no longer seems helpful to the patient's condition, revise your treatment plan now and take appropriate corrective action, such as changing to onboard oxygen if the portable tank has run out. Either during a radio report or upon arrival to the emergency department or other facility, introduce yourself and the patient and give a full report about the patient's chief complaint, presenting problem, history of present illness, past medical history, vital signs and physical exam findings, treatments, and response to those treatments. Document all of the above, including any observations about the scene, on the patient care report.